central coordinating office for many of the
This meeting is being recorded.
Addiction-related efforts that we have ongoing across the state. And so we serve to coordinate everything from prevention, early intervention, treatment, recovery, reentry services, and try to serve as a resource for programs that are implemented across the state. And we work very closely with the Bureau for Behavioral Health, Bureau for Public Health, with Corrections, with Department of Education, with an untold number of community programs, harm reduction programs, quick response teams, law enforcement agencies, law enforcement assisted diversion programs. We work very closely with the University of Charleston, which distributes the majority of the naloxone that goes out throughout the state through grant-funded mechanisms. And so anything that we can do to help you all do your job better in serving patients and helping people achieve recovery, we certainly want to be involved in that and want to hear feedback on things that you feel like that we could do better, or that programs that maybe other states are implementing that we should bring here to West Virginia. As I mentioned, my name is Matt Christensen. Was appointed to this position by the governor in November of 2020. So I've been here about 1.5 years now. My background's in medicine, and I work in a medication-assisted treatment program and practice through many of the changes that I'll be talking about, many of the policy changes. And so I've seen it from both sides. I've seen it from that medication side, but then also seen it from the policy side where I sit now. I also serve as an assistant professor in the Department of Family and Community Health, Division of Addiction Sciences over at Marshall. So I want to give just kind of a brief background and kind of level set for the group as to where we're currently at with regards to substance use disorder and overdoses in the state. Now, as you all have heard about a little thing called COVID, and which is primarily a physical health issue. It's a virus, but it's had dramatic impacts on the mental health and behavioral health of the nation and the entire world, to be honest, and certainly people with addiction have not been spared. This is our chart that looks at the number of responses for overdoses that have been seen by either emergency rooms, emergency departments, or by EMS. And the yellow bar is the combined of the two, so it kind of gives us a broad overview summary. Usually these numbers track pretty closely together. But what we really saw was around April of 2020, if you see a big bump up there, April to May of 2020, which was right when many of the shutdowns occurred, which restricted access to a lot of treatment programs. It disrupted the connections that we know are so crucial to long-term recovery. Many MAT programs, which we'll be talking about here, went to remote services. They went to telehealth out of sheer necessity. That also disrupted many of the in-person groups that were being conducted and the individual therapy sessions that were being done. We've seen some peaks and troughs since then, but we've generally seen a trend back down towards our baseline over the course of the past, certainly over the past 6 months or so. And we know that overdoses are only really the tip of the iceberg. Whereas I see it as overdoses being on top. They're the things that are the easiest to see, the easiest to count. We know that any individual overdose is just a fraction of the number of people that are actually suffering in a particular community or state in West Virginia, for sure, with substance use disorder. And that's only a fraction of the people that are suffering from mental health issues and behavioral health issues. So this is really just a very narrow window that's easy for us to count and represent of the greater problem that underlies many of these overdoses, substance use, and behavioral health issues. We also look at overdose fatalities. Again, it's one thing that's easy for us to count and kind of see what direction we're trending in. So we use it as a proxy for substance use disorder, an imperfect proxy for substance use disorder rates. And we've seen, this is through December of 2021, those numbers since April have been dropping slowly over time, obviously not as quick as we would all hope them to be dropping, but they do seem to be trending back down towards baseline as we've moved on in the pandemic. I won't say over by any means, but as we've moved on. The CDC releases provisional data, which does show that West Virginia is doing better than the national average in the change of overdoses. And so we've seen, West Virginia as of the 12 months prior to February 2022, relative to the 12 months prior to February 2021, there was a 3% increase, and the U.S. as a whole had a 12% increase. We attribute all of that success to the work that's happening on the ground in your clinics, in your offices, and the number of people we've been able to get onto medication-assisted treatment, get naloxone, get access to treatment beds, recovery beds, and really link that continuum of care together. One of the critical pieces to our whole response as a state is our medications for opioid use disorder. And just to kind of, again, level set, I know a lot of you all know what medications for opioid use disorder are, but just to kind of provide a little bit more background, they are buprenorphine products, methadone, and naltrexone, which otherwise known as Vivitrol is the brand name. And there's an oral version as well for alcohol use disorder. We predominantly talking about buprenorphine here because buprenorphine is regulated through regulation that regulates what are called OBMATs. You might hear me refer to that, which is Office-Based Medication Assisted Treatment Programs, OBMATS. Methadone is regulated through OTPs, opioid treatment programs, and they differ from a regulatory standpoint. Much of the clinical benefit is very similar in the two medications, but I'll describe a little bit of the difference here towards the end, and certainly happy to answer any questions as we go. But medications for opioid use disorder are a proven way to help people engage in long-term recovery. That they work. There are concerns around the edges with regards to things like diversion of medications, overuse of medications. There's oftentimes concerns about, can someone be on medication for opioid use disorder too long, or are we tapering quickly enough? And I'm certainly happy to address my approach to that as a physician and the policy approach too that we try to encourage throughout the state. So they're not perfect. They're not 100% by any means, but they are a proven way to reduce substance use disorder rates, reduce overdose and overdose death. And there's a whole host of literature that shows that methadone and buprenorphine are both very effective in reducing harm and reducing death rates from the deadly disease of opioid use disorder. Buprenorphine and methadone differ not only in that policy piece, but methadone is a pure what's called an opioid agonist, so it binds that receptor and sends a strong signal downstream, and so that allows people to escape the high peaks of intoxication of illicit opioids and the fast troughs of opioid withdrawal, so that the methadone level comes up and it stays up and it stays stable. So you don't see people going through these really traumatic peaks and troughs that are associated with illicit or shorter acting opioids. Buprenorphine is different from a pharmacological standpoint. It's what's called a partial agonist antagonist. So it will bind the receptor, but it only sends a weak signal downstream. It also binds that receptor really strong. So you're going to think about that like a handshake. So it shakes the receptor's hand and it doesn't let go. But it also comes in and will kick all the other opioids off of that receptor. So it will kick fentanyl off the receptor. We'll kick heroin off the receptor. We'll kick OxyContin off the receptor. And that's why we get, in some cases, if it's given too early, you get a precipitated withdrawal syndrome, because it's shaking the hand. It's just not shaking it very hard, but it grabs the hand really hard. It just doesn't shake it very hard. Whereas some of the other more potent drugs that are prone to abuse and misuse grab that hand. Don't grab it very hard, but they shake it really hard. So that buprenorphine comes in, kicks it off the receptor, and doesn't allow those other things to bind. That's also why, though, buprenorphine is protective of overdose, which is different than methadone. Whereas methadone, the effect can be additive. So if you have methadone if an individual has methadone in their system and then they relapse or use fentanyl or heroin, those effects can be additive with regards to the respiratory depression. With buprenorphine, most people, if you ask them if they have a recurrence of use, they will say, I used heroin, but it was really a waste of money. I didn't feel anything. It didn't do anything to me. And that's because that buprenorphine is really tightly bound to that receptor. We've actually heard of cases, and we wouldn't encourage this by policy, but just as an illustrative piece, we've heard of cases of overdoses being reversed with buprenorphine because it does have that effect of kicking the opioid off the receptor and has less respiratory depression than heroin or fentanyl do. And that would obviously be in the case where there's no naloxone or opioid reversal agent present. That's certainly not an evidence-based standpoint, but we've heard of cases of that happening, which really does illustrate the component of buprenorphine which contributes to its role in harm reduction of overdose prevention. We know that medications for opioid use disorder Reduce self-reported opioid use, reduce opioid positive drug screens. They reduce HIV risk behaviors, largely through the prevention of injection drug use, and improve quality of life across a broad spectrum of measures. I've seen personally in my clinic people that are working full time, that are making their house payment, they're picking their kids up from school, they are back to a normal functioning life. They are on a dose of buprenorphine every day, just like people with high blood pressure take a blood pressure medicine every day, but they are successful. You would never know any different that they were struggling with an opioid addiction, but they are in long-term recovery on buprenorphine. So we do see, we also know that medications for opioid use disorder save money. So in spite of some of the higher initial costs for Medicaid programs, generally is where it's been studied, of therapy visits, of medication counseling visits, medical visits, and the cost of the medicine itself, lower use of emergency department and hospital care results in an overall system-wide cost saving. So it's a good thing. We should be doing more of it, and it saves us money long term, largely through better health outcomes. And there's very few things these days in medicine that you can improve quality of care, reduce healthcare outcomes, and ultimately improve someone's quality of life with very little other ancillary negative impacts. There's not much in medicine these days that we haven't already done that has this level of broad positive impact. So I'm going to talk about, we talked about some of the impacts of medications, of the benefits of medications for opioid use disorder, the problem that we have in West Virginia of overdoses and substance use disorder. So I'm going to go into the meat of the talk, which is some of the prescribing guidelines that have changed pre-COVID versus during COVID and then now. One of the really difficult things about operating an OMAT, office-based medication-assisted treatment program, which is largely what I'll be referring to today because that's where the majority of the MOUD treatment happens, is that there's so many regulating agencies. So BMS at the state level has a set of policies around what it takes to operate an office-based medication-assisted treatment program. OFLAC and through the OIG, which is Office of Health Facility Licensure and Accreditation. If that's not a mouthful, I don't know what is, but they also have a set of aligned but overlapping guidelines on the requirements to operate an office-based medication-assisted treatment program. For those of you that work in one, you know that, or prescribe buprenorphine, you know that you are required to have a DEA-X waiver license. The DEA has overlapping authority over the prescription of buprenorphine and methadone for the treatment of opioid use disorder. And that largely comes down to, when we refer to the DEA-X waiver, it's a waiver around the Controlled Substances Act, which prohibited the prescribing of opioids to individuals with addiction. And so as buprenorphine and methadone are both opioids, the DEA-X waiver, at least for buprenorphine, allows a pass-through around that, the Controlled Substances Act. And then SAMHSA also has significant amount of oversight in some of the regulations around the treatment of addiction. So before COVID, generally, and someone was starting out in an office-based medication-assisted treatment program, you would have a weekly visit with that individual. You would do the 4 visits, where just to start out, it was essentially 4 visits a month or 1 visit per week. 4 counseling visits were required as well, and at least one of those had to be in person. Methadone was generally started out daily, although individuals could move on to space out their medication amounts as they progressed in the program. Buprenorphine was weekly, as I said, and telehealth was generally not allowed for controlled substance prescribing or for the visits. These were all expected to be in-person visits, and the prescription of controlled substances through the DEA and SAMHSA regulations was also not allowed through remote-only visits. It would require, oftentimes a physical prescription that we would have to print out and give it to those individuals. So this is kind of the pre-COVID nuts and bolts. This is from a presentation actually that I did up at WVU, probably around 5 years ago or so, on medication-assisted treatment and OMATs, office-based medication-assisted treatment programs. These numbers, a lot of this has changed, so that the DEA-X waiver is still required. There was a training initially early on, and that's been not necessarily COVID related, but has been relaxed. There originally was 30 patients in the first year, then you can go up to 100, then 275. And then I listed there some opportunities for mentorship around MAT or MOUD treatment and the West Virginia-based guidelines. So OFLAC had a, again, I've talked about a lot of this already, but has their own guidelines around what it takes to run an office-based medication-assisted treatment program. This was some of the overarching requirements. Again, some of the big things were the Medicaid guidelines with the weekly scripts and the 4 therapy visits a month. At least one was an individual visit. So the other 3 oftentimes were group visits. Requirement for drug screening. But again, all of this was conceptualized as inpatient visits, as was much of the world pre-COVID. In January 31st, the Secretary of HHS declared a public health emergency. And then on March 31st, so just a couple months later, the DEA and SAMHSA both issued separate guidelines for use and operation of medication or of office-based medication-assisted treatment programs as in response to the public health emergency order. And 2 of the main things were increased access to telehealth, so to permit some of those visits to happen remotely, and then to allow for longer prescribing intervals as well. So the DEA came out with this really intuitive, very easy to read chart on how to prescribe controlled substances to patients during the pandemic. Our office has put together a few of these that we've all ended up at the same conclusion that we should really just crumple the whole thing up and toss it, because I think that the goal of this sheet was probably good, and they were trying to simplify the regulations, but I don't know if they got to their goal by the end of the day. Although it's got nice colors. So they essentially, if you look here, and we can certainly share these slides if they haven't been shared yet. In evaluating the patient, it says, has the prescriber previously examined the person? Yes or no. If it's yes, they conduct any needed follow-up evaluation by any method. It says in-person, telemedicine, telephone, email, etc., and then issue any needed RX prescription directly to the patient or pharmacy by method in part 2. So it says how to do that on the bottom. We're not going to go to the how to transmit it necessarily, but even if you haven't seen the patient in person, it says, is the practitioner data waived? Do they have a DEAX waiver? And if they do, they can still prescribe controlled the buprenorphine to an individual through telehealth visits only, even for a new patient that has not been evaluated in person. So that was a pretty big departure, and that took some getting used to and lots of questions back to DEA to say, are you sure I can do this? Are you sure I can do this? Are you sure I can do this? And the answer was always yes. And so they came out with a lot of guidance documents to help practitioners understand the change in that practice, that for buprenorphine, you are allowed to induct a new person individually on buprenorphine in an outpatient office-based medication-assisted treatment program, and it can be a new prescription as well. So that was some of the DEA guidance. The SAMHSA released some early guidance, but then revised it and showed that and said that they could use that telehealth, because originally it was allowed for telehealth services, but then they allowed it for telehealth for buprenorphine for new patients, and they allowed it via audio only as well. So you could do it on just phone visits. However, and that was only for buprenorphine or OBMATs, not for OTPs or methadone programs, and for new patients specifically. So OTPs can operate via telehealth and can do their services via telehealth, but that inpatient visit has to be in person. The Support Act was also passed, which set 100 patient limit in or established 100 patient initial limit in what they called qualified practice settings, which are settings that have kind of some more oversight, have experience of treating addiction, and they upped that kind of as a baseline. And the Support Act was not necessarily a direct result. It was, it came down during the time of COVID. But in general, there's been a push to open up some of the patient limit requirements, regardless of COVID. COVID probably moved it faster than it would have otherwise. But this has been, some of the regulations that were expanded through the Support Act happened, and we're moving prior to COVID anyway. So, but it did also open up access and ability of physicians' assistants, nurse practitioners, and other nursing professionals to prescribe buprenorphine in the context of their practice. BMS at Medicaid also allowed for telehealth and for telemedicine, including the voice only for medications for opioid use disorder, and allowed for billing for those purposes as well, so that providers could get paid. And then also moved during the pandemic. This was probably about 10 months ago. Moved Sublocade, which is the subdermal injection of buprenorphine, long-acting injection for 28 days, to preferred status to allow more patients access to that, and that does decrease the burden on patients. They don't necessarily have to go in for medication visits or don't have to go in and get the prescription done. They still have to comply by the rules of the office-based medication assisted treatment program, which is generally to start weekly visits, but they're just not getting that prescription at each weekly visit. So it does decrease the burden on individuals who have other competing obligations, childcare, work, other things. The caveat to Sublocade is that it is much more expensive. It's about 100 times more expensive than the sublingual buprenorphine products. And so as this is rolling out, there's, the state and BMS are continually looking at the cost impact to understand what the clinical outcomes are and what populations are most benefited by the subdermal injection. So for OTPs, opioid treatment programs, which are methadone, they extended the number of take-home days. So for clinically stable patients, moved them from 14 days, and then the next step, which is I'm calling clinically stabler patients, for up to 28 days. And so, that is an accelerated take-home schedule compared to the previous requirements. And in my talks with the State Opioid Treatment Authority here in the department, the counseling requirements have remained for the opioid treatment program specifically. Just checking my time here. So another thing that was relaxed was and I don't know that I thought I had a slide on here, but it might not have made it into the end. OFLAC and BMS also exempted made it not a requirement to do the required counseling that was originally set up in the original legislation and in the legislative rule that OFLAC has to follow, and so that was also a big impact, and the vast majority of programs that I've talked to have all gone back to that as it currently stands, to that at least weekly counseling visits for new patients, but as a best practice. On July 15th, just last week, the public health emergency was extended for 90 more days, and DHHS has said that they'll give 60 days notice prior to the expiration of the public health emergency, and so that will give states time to adjust or amend policies towards ideally things that have worked during the pandemic, and some things really have worked well. And I'll give my personal or clinical opinion warning here, taking off my policy hat and putting on my doctor hat, is that in general, I've seen that treatment and recovery services work well when you have a good rapport with a patient, when you build a relationship, when you're able to work through them when they're struggling and celebrating their successes with them. And those things are all much more difficult to do, if not impossible to do, in a way that drives clinical outcomes that we all want, which is more people in recovery, when you do it over telehealth. It's just so much harder to get at some of those individual drivers of what's driving someone's substance use or recurrence of use. That being said, there are many benefits to telehealth, and so I kind of add the caveat of there that they should be done in person when possible, and it has to take into account a lot of different things. I have a couple patients that have really severe orthopedic issues, and it's very difficult for them to get out of the house. And I also happen to know them really well, and I know that I know that they're on a good trajectory and are making progress in their recovery. And so I'm comfortable doing those visits by telehealth, because I still feel like we can have an honest conversation about what kind of things they're struggling with, or what kind of things are that they're doing well with. COVID surges, I put in their transportation or access to care, which is obviously a huge issue here in West Virginia. We've tried 2 ways from Tuesday to find long-term sustainable solutions to some of the transportation issues for patients living with addiction in rural areas. And, kind of paradoxically, if there is a silver lining to COVID, which I hate to even go there, but it would be that that they have much better access to addiction treatment services now because we can do so much more via telehealth and do so much more remotely. So so those individuals, I a lot of times for them, it's you do it via telehealth, or do they not come at all? And so I would much rather do those visits via telehealth. And so just to kind of summarize some of the benefits and that I've seen are that, again, you have more access to care, more flexibility for individuals to, they don't have to come and wait in the office for 4 hours in an afternoon when really they're asking their boss and begging their boss to take time off. And I would be remiss not to mention gas prices somewhere in this presentation. So you save money on gas, but there's also less cohesion with the group. There's less rapport that you build with the individual. There's less ability to provide that peer support and peer counseling that we know is so important, where people will mention that they're struggling with something and everybody else in the room has also struggled with the same thing. And then it's also much more difficult to observe some of those behaviors and some of the personality traits and the coping skills and the things that those kind of individual characteristics that are so important when you're working with somebody one-on-one and trying to help them be successful in their recovery. So those things are so important to understand and to help work with them through. So it certainly is a mixed bag. I think that and hope that, and will be as the director of the office, will be pushing for retained ability to work via telehealth and to offer services via telehealth. But I do think there needs to be some acknowledgement that there are limitations and that this is something that works very well for some people, but it's not for everybody. And especially early in someone's recovery, before that rapport is built, before they've built some of those barriers and had some of that direct one-on-one counseling about how to deal with difficult relationships, and it really is beneficial to have those visits in person. I did offer up here some resources of things that I look through to remind myself of all the different regulations from the DEA, from SAMHSA, from HHS about the public health emergency, and these are all things that certainly can share with the slide deck. Our office, shortly after I took this position, put out an informational sheet on in collaboration with the Bureau for Medicaid Services and the Office of Health Facility and Licensure and Accreditation, OFLAC, to help providers and prescribers understand how to provide immediate access to buprenorphine. There is a widespread misunderstanding that you got to have drug screens for everybody, that you got to do a whole biopsychosocial assessment before people come in, and before you write the first prescription, and that is not the case. There are certain things that have to be done, but generally those are when OFLAC is going in to look at a program, they want to make sure they're done within the first 30 days. The most important thing for someone that you can do for someone who's actively injecting heroin or fentanyl, who's at acute risk of death with a life-threatening illness, is give them a short course of buprenorphine while you figure all this other stuff out. A diagnosis of severe opioid use disorder is very easy in someone who is injecting drugs, because they've checked off almost all those boxes already by the very nature of that behavior. And so you can even admit someone into an outpatient MOUD program without an initial positive drug screen if the individual is deemed high risk by the medical director or treating physician. And so that's something that I would say anyone that's injecting drugs these days, with the potency of and unpredictability of the drugs that are in the illicit supply, now more than ever with illicit fentanyl in the drug supply, this is a deadly disease, and buprenorphine, at least as an initial prescription to start someone out, to bridge them over, to get through all those other important steps, is life-saving. So with that, I think that's the majority of what I got here. And so there's my contact information. Feel free to email us with any questions or concerns. And with that, we will open it up for questions.
Well, first and foremost, Dr. Christensen, I just want to thank you so much for taking the time to present today and sharing your expertise. We really appreciate you. And I will be attaching your PowerPoint in the recap email, so everyone will have a copy of your slides with those wonderful resources. But Dr. Hirschler, I noticed you unmuted, so I don't want to take too much time. I'll let you go ahead.
Yeah, I was just interested. I know access to care has improved with telemedicine, but what about engagement and quality of care? And I think all three of those are very important in the care that we deliver. What do you think about that?
Yeah, I mean, I think that I would say the worst possible answer is it depends. I think it needs to be a patient-specific decision, and I've seen and still see patients over telehealth who I know wouldn't be able to come into the office, and so. But then there are also people that when we went to telehealth just disappeared off the map, and because they were not getting the same quality or the same support and reinforcement that they normally were getting in person. And so I think it really is a delicate balance. I think we do sacrifice quality for access in this whole telehealth debate, and it's going to be an ongoing conversation about how we can balance those two things out in a way that ultimately benefits the patient that's sitting in front of us. I think that probably the best of both worlds would be, down the line, sort of as we space out medication visits and as we give people more leeway as time goes on, or less oversight with regards to giving people, weekly, biweekly, and monthly prescriptions, that we also think about using those telehealth requirements in that same way of saying, start out in person, make sure people are on stable footing, on stable ground, make sure they're doing well, and then maybe open it up to telehealth visits or remote visits, because it really is a lot to expect someone to come in every week. And in our clinic, it was 3 or 4 hours. It was a whole half day every week, and people that are trying to manage home life and work life and school life. We don't do that for a lot of other diseases. I know, addiction is its own beast, but it's incredibly burdensome. And then, if people fall off of our schedules, a lot of times it's just because it's so much work to be compliant in an office-based medication assisted treatment program. So it certainly is a balance, and but yeah, any insight that you have on it too would be appreciated about how we can find that right balance.
Thank you so much for the question, Dr. Hirschler, and that great response, Dr. Christensen. Any other comments, questions from the group? Anyone else who has experiences with telehealth versus in person?
I have a question. It's not about telehealth, though. I wanted to know, Dr. Christensen, what your thoughts are. We've seen an increase, at least I have, of patients asking about the medical cannabis card and how that should play into their OB-MAT treatment, and if it should be allowed or not allowed. Has your office had to deal with that question at all? And what are your personal thoughts about that?
Yeah, that's a great question, and it's incredibly complicated and nuanced. There's not many other, or I can't think of any other disease really that has where the indications have been decided by a deliberative body outside of the FDA, maybe. So it's really difficult. I mean, we know cannabis has being medicalized. It's being moved into the medical space in a way that a lot of prescribers, quite frankly, aren't okay with, and other behavioral health professionals. And it's and so it puts us as prescribers and behavioral health professionals in a difficult box of saying, what do we do if someone is following all the rules and they've got a legitimate medical cannabis card, and they got it through legitimate means, and they're not in violation of state law. I think that we need to treat it like we treat alcohol, which is a legal substance, and determine whether it is a substance of misuse for the individual or a substance of addiction that the person is using it as, or if they're using it as a coping mechanism to not deal with the prior trauma that they're previously maybe addressing with opioids or stimulants. And so it's again it's it's a bad answer, but to say that, to fall back on the fact that just because it's illegal, or sorry, just because it's legal and done through legal means, doesn't mean it's okay from a substance use disorder standpoint, and is not part of the treatment plan, which is we want you to deal with those underlying issues as opposed to just trying to cover them up with another substance. Same thing with I've had patients that come in with legal prescriptions for stimulants, and so we got to kind of go through the rigmarole of making sure the diagnosis was appropriately established, and making sure they're not misusing it and it's providing some clinical benefit. The problem with cannabis is that there is really, in the medical literature, no evidence-based medical benefit as it currently stands. I mean, that may not always be the case, but in its current status, where we don't really have refined versions other than a couple for Marinol and another one for refractory seizure disorders, there's not really any kind of cannabinoids that have gone through that rigorous medical testing for us to be able to say that there's a clear clinical benefit. So it's really difficult. There is on the medical cannabis website, there is a link at the bottom where you can go down through and you can verify whether someone's card is legitimate. And it's essentially, and the patient has to agree, obviously, for you to allow you to do that. But but that if that makes a difference in your clinical decision making at that time, but it's going to be something where we're going to see an uptick, as many other states have, in the use of medical cannabis, just because it's legal now, it's more accessible, and it will be an evolving conversation as to how we deal with this. I've had a lot of conversations with treatment court judges on the exact same question about what do they do when someone has a legitimate card. This is someone who's in a treatment court with an agreement with the court not to use illicit substances, and it's still a Schedule I substance with no medical benefit according to the DEA. And so that puts them in a very difficult situation too. But it's certainly an individual question. I mean, I think a big part of it comes down to dispelling, at least the way that I fall back on it, is in dispelling the myth that it's harmless and that there are no medical issue, or that there are no medical issues with it. It's certainly not as harmful as many other substances that people use. There's no doubt about that. But it's not harmless. It's not. It's just not.
Thank you for that question, Tony. Any other thoughts from the group? Questions, comments?
I would be curious if there are other people that work in outpatient medication assisted treatment programs, or OTPs, what their overall experience with telehealth has been. Has it been positive, negative? Has it been something that should stay the exact same way it is forever, or should it be completely abolished, or somewhere in between?
This is Laura. Our experience has been, at first I really struggled, and then I came to see the benefits in some of the ways that it was even better. So certainly access is greatly improved. But if people are struggling, they're a little bit harder to manage and really know what's happening with them. And then I would agree with a lot of the points you made about group cohesion. And we've tried to bring some of our groups back, and there's been a fair amount of pushback on that because of all the barriers with regard to transportation and the cost of gas and things like that. But I do believe for a certain subset of patients, it would be better to have them come in person. But do you require them to do so at the risk of losing them and having them drop out of treatment? So that's really the struggle that we've encountered.
Sounds like a good research project.
Right.
Predictors of success in MOUD, telehealth. Obviously it's lower on the intensity of interference or of burden on the patient, but at the expense of some quality and effectiveness, I think, too.
I also did have a quick question. This is just very, very specific. So prior to COVID, we had the requirement in outpatient MOUD treatment that patients were required to have individual therapy as part of their treatment. And during COVID, that individual therapy requirement went away. Is that, I'm a little confused as to whether it's back or not. So in addition to other modalities like group, is there an individual therapy requirement?
So the therapy requirement was completely removed by BMS and by OFLAC. That will be, so BMS says that they've reinstated theirs. OFLAC, and I had this email out probably just a half an hour before this call and haven't heard back yet. OFLAC says that their requirement to remove that has not, or their flexibility of, I guess, removing those in-person visits still stands. And so I've got conflicting answers from BMS and from OFLAC on that. So let me, so I sent an email to clarify and haven't heard back yet. So let me follow back up with you on that, and we can send that out to the whole group.
All right. All right, then that's good. It makes sense that I'm confused. That makes me feel better.
Yeah. So they gave me. One said it has been reinstated, and the other one said it was been removed. But they also have overlapping authority in that area, because one specific, Medicaid is specific for billing, OFLAC is for licensure,
right?
And so those are sort of two overlapping, but they need to be aligned, which is part of the reason I'm here, is to say talk to each other.
Excellent, thank you. We appreciate that.
Yeah, we'll clarify that and get that back to you.
Hi, this is Laura from Minnie. Am I the only person that didn't know that the individual therapy had been relaxed? I've been making everybody do individual therapy once a month the whole time.
Oh, we've still been making it a requirement as well. And actually we kind of doubled down on it.
Okay.
More so because our population needs more individual therapy.
Yeah, I don't plan on changing our approach to that either, because there's just too many of them that we don't get the same interaction with them in a group setting as we do in the individual.
Yeah, we've known that it was relaxed, but we still pretty much made it a requirement still for the same reasons.
Yeah.
But yeah, I had a question though, and I want to know what you all think about this. You know, this is Dina, by the way. When we think about our treatment of patients with like hypertension and diabetes, one size doesn't fit all. I always wonder why the state requirements are that way in terms of therapy for our patients. Because we know we have patients who, because their life is not chaotic, they do well on just buprenorphine and actually seem to not require individual therapy or group therapy, no relapses, maintaining good family life and their jobs. Why is it the state doesn't allow the provider to make flexibility with regards to patients, so one size doesn't fit all, and we can sort of say, well, this patient needs more support, this patient needs less support?
Yeah, that's a great question. It was a little bit muffled, so let me just restate the question, and you can say yes or no. So why does the state require the therapy sort of as a broad brush for everyone, regardless of their clinical trajectory, even if they're doing well? It's just a universal requirement as opposed to clinical discretion. Is that the question?
Yes, sir.
Okay, great. Yeah, that's something that's been discussed and hotly debated. As of right now, it's in statute that those and in legislative rule that therapy is required. There are flexibilities for expanding out that therapy as time goes on. So as people are successful after 90 days, they can go to stage 2, and then after a year they can go out to stage 3. But it is it is burdensome for some patients. Some patients clearly need it, and so I think the intent at the time was to provide a minimum standard by which we could not only treat the opioid dependency symptoms, but then also address some of those underlying issues with therapy and counseling. So, you know, I'm always an advocate that these things should be, that there should be flexibility with regards to clinical discretion to make sure that each patient is provided the optimal level. But as of right now, that's a legislative rule and something that's unchangeable as it currently stands, short of readdressing it at the legislature.
Any other thoughts or questions from the group? This has been a wonderful discussion. Alrighty, well, if there are any questions after the fact, you can always email myself or Elizabeth, and we'll make sure to have them addressed and sent back to you. Thank you again, Dr. Christensen. We really appreciate you taking the time to join us today, and we would love to have you back anytime you can. So the only announcement that I have is that our next session will be on August 8th, and Dr. Mark Garofoli will be presenting on hallucinogens, stimulants, and cannabis. So keep an eye out for that reminder, and we hope you have a wonderful evening. Thanks, everyone. Take care.
Thank you.